What do you think? What do you see? Diaphragmatic. Okay. So does he have an increased work of breathing?
Yes.
Yeah.
Does he have an increased respiratory rate? Remember, those things are different. Okay, so he's got a tachypnea and he's got an increased work in breathing. We also can see that he's got an O2 mask on, so his FiO2 is increased, not surprisingly, from that. So with regards to respiratory failure, we don't know a SAT on this baby, but where would you put them? Compensated, decompensated? How would you again tell the difference? How would you communicate this? So it is hard to say. The brain is switched on, is functioning, end organ oxygenation and perfusion is present with regards to that. There's an increased work of breathing and he's on an increased FiO2. So we'll assume that he's, from this, decompensated, okay, respiratory failure. The thing is that if he's on the SAT monitor, his SAT might be 93%, but he's on O2. So that doesn't take him away from being a decompensated respiratory failure. He's just being treated and he's reliant on an oxygen concentration that's greater than air. So in air, normal room air, if this child was breathing away like that, perhaps might be a little bit more somnolent and was in a hypoxic presentation, so SATs were 88, then that's your decompensated respiratory failure, how you would communicate that. You put some gas on them, into position, the fact that he's tolerating the gas, he's working hard, and the SATs come up. Are we out of the danger zone yet? No, not at all. Because what's keeping him alive? Silly question, it might seem, obvious question. But it's his ability to work hard and breathe. So babe is still working hard, and what does he need to work hard? He needs more oxygen than normal, and he needs more energy and more sugars and everything else like that. And what do we say at the beginning? They have low reserves, they desat quickly, they become hypoglycemic, as well as whatever the underlying problem is. Okay? So, alert-wise, if we just looked at his head and we took the mask off, doesn't look too bad. But when we break it down to this, we're talking about potentially an example of a decompensated respiratory failure. Okay, so we need to try and intervene and support and do as much as we can. We're looking for goodness. We're looking for an improvement and nice numbers, because nice numbers make us feel better. But nice numbers don't fix patients. We need to buy time to get them to the right place to do the right investigations to try and sort out what the problem is and reverse it. Okay, so having again looking at this, at signs of work of breathing as well, you need to get down to skin level. You need to examine the chest and the abdomen. You can see that you've got subcostal recession here, so there's some increased work of breathing, some real effort that's being put in to do with this. The child, if not sedated, is somnolent. So if there's no sedations or anything else put in for this is because now, he is tiring, he's fatigued, and potentially underperfused, hypoxic despite O2. He's got a mask on, which is great. He's got a non-rebreather mask on, which is awesome. Unfortunately, the reservoir bag's not inflated, it's stuck together, and we get that a lot. They sit in the cupboards, the heat and the cold and so on. So making sure if you're going to use a reservoir mask, then that reservoir is inflated, so there's ability to try and draw out a higher concentration of oxygen if needs be. Okay, circulatory. Assessing circulatory, so do we have compensated or decompensated circulatory failure? Looking at heart rate, colour. Colour is probably one of the first things that you will see when you walk in. So the colours that we may see in the sick child can still be pink and flushed, can be blue, can be white, can be grey. Okay, so pink, okay, that's better than blue, but I'll take blue over grey, because grey often refers to a sick or septic child or someone like that. And white typically is hypovolemic, hemorrhagic child that may be in front of you. And as first responders, for any patient that's lost blood, we can't do much about that. Our salty, toxic water is not particularly good and doesn't give a great advantage. So we need to get to where we can replace and turn things around as far as that goes. So taking of pulses, particularly again in infants, the central pulse is carotid, really, really difficult, so we tend not to bother. Brachial is an option, because radial can be really fiddly and so on. But ephemeral is probably a pulse that may not be used as much as it could do. So a central pulse typically will go in an infant is ephemeral. And one of the good things with that in exposing a small child is that you have to undo the nappy, and this allows you to get down to skin level and do a good assessment. Obviously appropriate to context. Okay, so just an irritable with a bit of a fever, but otherwise okay, and then wanting to strip everything else off. So it's appropriate within context, but don't be afraid. If you have a femoral pulse, then try and go for a brachial or a radial pulse and see if there's any difference between top and bottom circulation. Might give clues to congenital defects and so on, particularly in the small infant. But looking peripherally and centrally for perfusion and cyanosis and delayed capillary refill is really useful, because we know that peripherally they tighten up, and that ability to tighten up can keep the brain switched on and the central circulation really, really good, and trick us, unless we are more curious, into thinking the child's not that bad. But if, as you pull up the clothing and you notice there's a change in colour, sometimes that's difficult in darker pigmented skin, but temperature as well, and other extremities to look to see whether there's signs that uniformly there is some change in temperature and signs of increased systemic vascular resistance. Cyanosis, as a colour, really we're interested in central, and centrally the lips can be a bit misleading. I tend to look at the tongue, the gums and so on, looking intraorally, and if that looks blue and dusky, they are centrally cyanosed. Sometimes periorally, peripherally around here, can be slightly dusky, but that's peripheral perfusion. That's not true central perfusion. So just be mindful of that. Okay, and the capillary refill test, which we're familiar with, 5 seconds on, and then count for how many seconds it takes for it to refill and return. And being mindful that it's not just venous return as well. Okay. So where that limb is in relation to that. And for adults or children, less than 2 seconds is normal. Being mindful of the ambient temperature as well. So cold will cause children to shut down. So these are the questions that you're typically asking. Once you've done your ATOE assessment and you've considered respiratory assessment, a circulatory assessment in the context that we're dealing with, is my child stable? Do they have compensated or decompensated respiratory failure? Do they have compensated or decompensated circulatory failure? Do they have both? What am I calling it? What help do I need? We're coming in. This is what I think we've got. And, it's quite a powerful communication tool. And the challenge to do with this is holding your ground initially to do a sound assessment and discovering what you think you've got regarding a clinical status of a child. So not necessarily an end diagnosis. You want to have a working diagnosis based on some of the history, but initially you want to know your clinical status, and it falls within these categories. Okay. So as you focus towards your airway and breathing, that's going to address deficits in oxygenation and ventilation. Circulation is going to deal with your perfusion. Medical transfer, so ambulance and so on. The reason for medical transfer that we can either call in more help, more resources, or get the patient to a place where there is more help and more resources. But personally, when we often refer to ambulances, we talk about scoop and run and stay and play. Okay, and I believe that's a dated paradigm in how we should look at it, because neither are applicable. Okay, what perhaps we should be renaming it as stabilize and protect for appropriate transfer. So we're talking about RFDS with a critically septic patient 2 hours flight away. there's a lot more that needs to be done before that patient embarks on that journey. And so staying in plane, well, no, it's appropriately treating for the journey of transport. If we are 5 minutes from ED, then again, appropriately what needs to be done to stabilize and protect for appropriate transport. Rarely is that with a floppy child, just picking them up, sticking them in the back and putting the foot down. The very basic approach of doing an A to E assessment and fixing gross deficits in A, B and C are what we are supposed to do. And that should not take a long period of time. And even if we're a short distance away, if a patient's about to crash, if we're into that peri-arrest phase, then we need to step up and deal with it. We don't want to waste unnecessary time at all. We need to get to a proper centre of care, but we need to do that safely and appropriately for the patient. And a big part of that is communicating. If we don't communicate appropriately, then the help we're going to are behind the ball by the time we step in. And so a lot of these references and terms that we're talking about is a good way to actually share what you're dealing with. So, okay, there's supposed to be text on the other side of this. And I really don't know why it's not showing up because it's white background. But when we're looking at treating, there was just a little bit of a chat about medications. So medications and so on. Children come in under the banner of pediatrics, come in a vast degree of shapes and sizes. And so when we're looking at the interventional level of giving medications and fluids and treatments to patient, we then focus on a weight-based approach. So we give the appropriate amount and concentration for that patient. There's quite a few people that argue that we should be doing that for adults as well, weight-based, because adults come in a huge array of shapes and sizes as well, and yet we give a single dose. Now, we have the pediatric weight-based formulas that we use, and there's quite a bit of variability to do with that. APPLS, as I mentioned, Advanced Pediatric Life Support, have 3 different formulas according for which age group that you're dealing with. In the UK, they have 1 formula, and I had them up there. Within service here, and again, the focus of this, although we're talking generally wherever you do work, you follow the scope of practice and the direction that you fall within. But you open up the literature and you have a look around, you realise that invariably there's always changes from one system and centre to another. So, one of the things with regards to the formulas is that it will give an approximation of an appropriate dose to that patient. The UK and the Resus Council formula that we had used before generally underestimates and works more towards ideal body weight. The APPLS formula, particularly the one that we're using here, tends to overestimate a little bit and is perhaps more applicable to, particularly in the developed world of children who are becoming more obese, might sort of marry up a bit closer with that. But the other thing we need to bear in mind when we're giving drugs is what do the drugs do and how do they work? And there are some drugs in their dosing that is designed to be lined up with ideal body weight and others with actual body weight. And a lot of the Resus drugs fall in with ideal body weight. So no matter how much fat you have, they're water-soluble drugs and you're sort of calculating them based on the ideal body weight of a patient, because no matter what your fat content is, your body weight or hydration, fluid levels don't vary that much. So there's a good paper that I came across, which I can pass on later, that just actually looks at the accuracy between these different systems, and that's essentially the consensus that you have, and understanding that really there isn't a one-size-fits-all to do with that. Big thing, as we're coming towards the end now, is drug errors, particularly in paediatric patients. There's a number, if you look through the literature of actually US paramedic studies, but great for the US to actually do studies and have a look and publish stuff like that, because I guarantee it's going to be in every setting. But one of the most common areas of drug error is pediatric cardiac arrest adrenaline. And again, the reasons for drug errors in any setting are often either some or all of the things that are mentioned there. It's a high stress event, and there isn't anything that becomes really much more stressful than a pediatric cardiac arrest. And yet we have to decant and dilute and calculate a drug dose with 2 or 3 of us. So, of course, there's a huge opportunity for error, and these errors do happen. So, recognizing that errors are very much a reality, we need to try and actually address and minimize these errors as much as possible. The focus of, despite the urgency of this, is that the importance of checking, cross-checking, and trying to reduce the stressors in the setting, which comes down to interpersonal activity, communication. There is a study that referred to in-hospital communication, and actually if your team or team leader is rude, it has a proven detrimental effect to the outcome of the patient, as opposed to your team leader being not rude. So rudeness kills. It's not nice, but it kills. So, it all has an effect to do with that. So, dedicated drug person, great if you have it. Standardized administrations, we struggle with. How do you want it drawn up? We can't always agree when it's adults, let alone peds. But practice does play a really important role in reducing errors, and that's how you really can make progress. Have these questions. What is the best way to actually deal with this? What's the best way to draw it up? What's the best way to introduce it? If you have to draw up a drug and set that up because you want to give some cardiac arrest adrenaline, and in the process of doing that, that means you abandon good chest compressions or you abandon good airway control and good ventilation, then should you be doing it? What gives you better return and better yield and so on? So, always do the simple things well. A couple of cases just to finish. So you've got a 9-month-old with breathing difficulty. They have a rapid respiratory rate. They have a temp of 37.8. Assessment has a clear airway. Rate is 45. There is an increased work in breathing, generalized bilateral wheezing, and a SAT of 90. Tachycardic, BP is normal, good peripheral perfusion, CRT is not delayed. They are alert and orientated and no signs of any other concern. How would you manage this child? What category would they fall into? Shut up. You know how to do some things, so what would you do first? A. Do you need to do anything with A? Overall wellness of the child. Bit concerned, a lot concerned, terrified. A bit concerned. And why are we a bit concerned? Breathing, yeah. So we seem to have a breathing issue. Is it a horrible breathing issue? Are they compensated respiratory failure, decompensated respiratory failure? Compensated. Yeah, and we've got that typical, well, why? If you just put 89%, then it's decompensated. It's really easy, and he's on the fence. You give it a call. Okay, that's fine. So we communicate that. We have this. We've got a compensated, you say respiratory failure, we've got a problem. But he's compensating at the moment, but we have a problem, so we need to do something. And what are you going to do? Or how are you going to do it? You're going to give him oxygen. How are you going to give him oxygen? Through? Okay. Child's conscious, fully orientated, 9-month-old. Going to be cool with that? Maybe not. Okay, mum holder. Okay, yeah, things. So this is where other strategies come in. And do we feel quite comfortable using other strategies because do we feel he's on the precipice and about to fall off? Not yet. It may come. Might not be today or in this shift. Okay, so management, child-friendly approach, O2 therapy. That's good to have because he has a DSAT, increased worker breathing, compensated, borderline decompensated respiratory failure. Doesn't seem to be any big red flags with regards to circulatory assessment. Reassess A, B, C, D, and actually now your expert advice of what is the respiratory problem and what's it likely to be at that age and what's the most suitable treatment and therapy. Okay, case number 2. You've got an 11-month-old, 2-day history of diarrhea. On admission, has shallow, rapid breathing, temp is 37.2. Airway is at risk because the child has a reduced level of consciousness, floppy, some extra movements, clearly tachypneic, got good bilateral air entry, but a lower than normal SAT. Very tachycardic, cool mottled peripheries, and a delayed capillary refill. What would you call this? What would you do? Okay, so decompensated circulatory failure. Okay, why decompensated? What triggers this for being decompensated? Numbers are good. Okay, blood pressure might be a little bit low. Cat refill, yeah, but what's one of the big signs that you get? Drowsy and withdrawn. So end organ perfusion. The premise when we mentioned before is that vital organ, is that still going okay? Heart rate's working okay. But yeah, we quite likely, I don't know what's the normal range of BP or systolic. I might have to look it up or look at the reference card that we have. But it seems a little bit low. Yes, you've got peripheral involvement. There's tightening there. But the thing that's really concerning is that this child is floppy or lethargic or irritable and so on. It's showing a sign that the brain is struggling. And its strain initially could be because it's underperfused. Child shocked. Red flag. Okay. All right. So, management. Craig.
Will there be baby things falling completely straight away, so you want to try to reverse that?
Okay. Where would you start though? First things that you would do, sticking in the tradition of the alphabet. Yeah, that's it. And it's really good because you see, it's a really good point. You see this has happened so much that we see, I've got a circulatory problem. So I need to get lines in. How easy is it going to be to get a line in this 11-month-old shut down child? Really hard. And the thing is, it doesn't matter how big the line is you put in it, you can't breathe through it. So you have to address the A's and the B's and find, or get someone to do that whilst you're getting the best person on this. But the chances are, what's your route of access that you're going to tip IO? Because you want to give fluid. So you might skillfully be able to thread through a 24 gauge cannula with a flow rate of 13 mils a minute. So what would be the fluid bolus for this child? Let's say they're a year old. What's their weight typically?
10 kilos.
10 kilos. And if we worked on 20 mils per kilo as a fluid bolus, because it seems to be a circulatory failure, what would that be? 200 mils. And we're going to thread through a 24 gauge, 13 mil a minute, and I want to give a meaningful fluid challenge now. So an IO, even if it's little red, pink, easy IO, is a 15 gauge. You're sticking in between a grey and a brown cannula into this infant, and you will give a flow rate of 200 mils a minute. So you can get that fluid challenge in within a couple of minutes and pushing through as opposed to the next 10 minutes. And that could be crucial at this setting. So really good point. And that needs to happen. That seems to be the principal challenge. But we still need to address the rest of the problem. So we need oxygenation. Although there's not a lung problem, they are borderline hypoxic because they've got circulation going not very far. Okay, and our brain is telling us, or their brain is telling us, it's really not good. Okay, and these things need to be done, even if we're 10 minutes from hospital, but we don't want to spend 30 minutes doing it. Okay, so again, it needs to be clear, decisive, and then actually good care as we go that's appropriately managed. Okay, last couple of slides. There's a few different things just to bear in mind. We just talked in the last case with regards to fluid boluses and so on. I came across a little while ago a really interesting podcast, which was an ICU-based podcast, but basically on the workup of the sick infant and neonate. Very simple premise from a chap, pediatric intensive care consultant called Michael Grixatis. And he does a lot of teaching, and in this podcast or his presentation he used an acronym called Scamps. And this is his process when dealing with that cardiorespiratory failure child, the floppy, sick child, of actually keeping in mind a bit of a structure as you deal with the A, B's and C's. And that Scamps refers to consider sepsis, consider cardiac for congenital abnormalities or acute infection, consider abuse, metabolic disorders, and seizures. Now, in pre-hospital and ED, we can't do everything about this. Remember, this was an ICU setting. But the thing is that cardiorespiratory failure, floppy, sick, tachycardic, tachypneic child can look the same in all of these presentations or all of these potential differential diagnoses. So if somebody just latches onto one, they can ignore the other. And that can be to the detriment of the patient. So this is across the board, but giving consideration for that. Could it be sepsis? What's the history? What's gone on? So on. Could it be cardiac? Have you listened to the heart? Have you palpated the liver? And this is one of the things that he emphasized, was that neonates and infants are essentially sort of born with weak left hearts already. You know, the in utero circulation is right side dominant. And as we grow up, for all of us here, our circulation is left side dominant. But because of the in utero circulation, right side dominant. And it takes a while for them to switch over and grow a stronger left heart. And with that in mind, that with infants and children that can squeeze their peripheries and raise their central pressures brilliantly, better than at any other time, they can actually cause the heart to go into failure. So this collapsed, tachycardic, unwell child, from a number of different reasons, can actually not have a particular volume problem, or if you give a fluid bolus, you can actually cause harm. So just bear that in mind. Don't rush in with the fluids if you think you've got circulatory failure in a neonate or an infant particularly, because you may actually cause more problem, more harm. Stretches beyond the scope of here today, but ways of actually looking to see whether you have sort of an over-volume or centrally volume patient is assessing the liver and the liver edge and percussing or palpating to see whether that is distended, giving a sign of increased central pressures. Ultrasound is a quick and easy way to have a look that if that heart is underperfused and going like the clappers, then yeah, give fluid. But if you see that heart distended because they've tightened up everything so much and they've got a weak left side, then fluid will not be good and you might need inotropes or so on. Okay, debrief. Always necessary. Always do it. Remain constructive. Remain supportive. Talk about it early. Sometimes there's tensions to do with that. Sometimes, and quite often, an external person can be useful. In our workload and high demand, it can be really difficult to actually achieve it. But I can't emphasize the importance of doing that. And there's a number of times through my career when that wasn't done, and I still very much am aware of those things. We sort stuff out largely on our own, but sometimes very small things that can get overlooked can be talked about and not become the big sort of shadow that some people may end up carrying around unnecessarily. Okay, can't see any of this. Basically, it's about, if you want to stay on the fat man's list, okay, and not drop the ball in looking after sick kids, it's about preparation, it's about training, it's about good communication. How you look after and deal with your next sick child starts here. It started in your training, and it only gets better, and because it will come, with the more practice, the more communication, the more thinking you spend on how do I deal with my next job that becomes a one-year-old floppy infant, and going through those processes. What are the calculations I need to do? And drill it, because it needs to be more than just mental pictures and conversation. It needs to be practical, sort of muscle memory building skills. And we all need to do it. I do it because I don't get to see patients like that often. There's some stuff that we see almost every block, if not every day. We don't need to practice that too much. We need to make sure that we're on track and up to date. But there's other stuff that we do need to invest a serious amount of time in order to do. So, I hope I haven't blown your minds too much with regards to that. The focus is on getting the little kids to become big kids. If you have any questions, happy to take them. If you want to contact me at any time to discuss any of these bits and pieces, and I think the presentation in all its glory will be up on the site to refer to, then you can do as well. Cool, thank you.